So as Rachel mentioned, I did a presentation at the Huddle a couple of times ago, a month ago or so, which focused on this question about long-term trends in GP practice consultation rates. And that's one of three outputs that we've produced for the Midlands Decision Report Network that will be published in the next week or so. The other two reports focus on the gap between need and supply of GP practice consultations, and that's what I'm going to cover today. And then the third report is focused more on this issue of GP practice productivity and continuity of care. I'll just remind people what the sort of headline conclusions were from the last presentation, first of all, and then I'll move into this more general question about the gap between need and supply of practice consultations. So the analysis that I showed you last time suggested that consultation rates had been increasing fairly steadily between 1995 and 2012. And then they started to decrease and reduced until about 2019. And then after that period, there's a lot of uncertainty about what's happened to GP practice consultation rates. Some of the sources that we used suggested that consultation rates had gone up since the pandemic. Others suggested they had come down. And just to give you some, what I spent most of the time covering at the last huddle was alternative sources of information that might help us understand what really had happened to consultation rates. So patients are reporting lower levels of access to GP practice consultations. And when we asked them when they last saw their GP or last saw somebody last had an appointment with their practice, they report longer intervals than they had in the past. But the workforce has increased, and NHS Digital's appointments data suggests that appointments have gone up. Referrals, though, have gone down, and prescription rates have also gone down. So it really is a mixed bag in terms of what the data is telling us about what's happened to consultations. And really what the sort of headline conclusion, I guess, is that the changes to the way in which GP practices have operated over the last few years are making it more and more difficult to count what's happening in GP practices, and simply counting consultations or appointments might become less useful as we go forward, as the different ways in which practices interact with their patients change in the future. So that was what we covered last time, and I'm going to move on to cover this second question about the gap between need and supply of GP practice consultations. And these are the sorts of business questions that we're attempting to answer in the analysis. So we want to understand whether there is really a gap between need and supply, how big that gap is, if it does exist, how it's changed over time, whether it's bigger in some ICBs than others, and what the consequences are of that gap for patients and the wider health system. So those are the questions we're attempting to answer in this analysis, and I'll come back to these at the very end of the presentation and give you my perspective on those, having done the analysis. The analysis itself is based on this period between 2008 and 2019, when there was greatest certainty, I guess, about consultation rates, which I know isn't ideal. We'd love to get a sense of what the gap is now, but given the difficulty measuring GP activity at the moment, I think that would be a really difficult task, and we need to do more work to really be sure about what's happened to consultation rates since the pandemic to make a good job of estimating gaps between need and supply after the pandemic. So what I've done in this analysis is focus on that period where there is greatest certainty about consultation rates. And this is the analytical question rather than the business question. This is the analytical question I'm attempting to answer. So what I'm looking to answer is whether or how much more or less likely it is that a patient will receive a consultation in a given time interval in 2019 than a similar patient would have been with similar needs in 2008. I'm just going to break that question down a little bit. So this is the effect size that we're trying to estimate. This is the quantification of the problem we're trying to get a handle on. This is the outcome that we're interested in, whether a patient will receive a consultation or not. This is the year of interest, 2019, although it could be any other year between 2008 and 2019. And this is our reference year. And when we say a patient with similar needs, in effect, what I'm saying in this analysis is a patient who has the same age, sex, lives in an area of similar levels of deprivation, and has similar morbidity levels. And we don't need to specify that time interval. It can be any time interval less than a year, but we will get the same answers if we were trying to compare someone's relative chances of receiving a consultation within a week or a month, because we're comparing two similar patients, so the interval isn't particularly critical. Rachel, by the way, usually encourages me to say a little bit more about the methods that we've used in these analyses, and I usually shy away from that because that's more difficult to do, but I'm going to attempt to do that in this presentation. So I'm going to talk a bit now about the sort of technical underpinnings of the analysis we did. You'll have to tell me at the end whether that's useful or not and whether I've made a good job of it, but I'll attempt anyway to show a little bit about the analysis that sits beneath the results that I'm about to share with you. So the data set that we assembled was 20,000 patient years from each of the years from 2008 to 2019, and we drew those patient years at random from CPRD Gold. The CPRD Gold is one of these research databases that includes lots of information about patients' experience of GP practices. All of the clinical information that's collected as part of their interactions with practices are collected and summarised and curated within this research database. And the data set itself has these variables in it. This is the data set that we've gathered and assembled. So first of all, this is our primary outcome, the number of consultations that a patient receives. So each row in the data set is a patient year. So this is the primary outcome, the number of consultations that they received. This is the variable of interest. We're interested in understanding how the number of consultations changes over time. These are other variables that we want to control for that might indicate the levels of need of the patient. This is an exposure variable. If a patient was registered for the whole year, then we might expect them to receive more consultations than a patient who was only registered at the practice for, say, 6 months. So we need to take account of how many days a patient was registered at the practice within the year. And these are secondary outcomes, which I'm not going to really focus on today, but are included in the report if you're interested. So we're going to mainly focus on this primary outcome, the total number of consultations that a patient receives. And then we've done with that data is try to use it to populate a model that we've developed. And the model is a regression model, and this variable here is our outcome variable, the number of consultations that a patient receives. And we're interested in how that variable changes as a function of other variables, such as year. That's our variable of interest. These variables here, which are a description of the need of the patient, their age, their sex, the level of deprivation they live in, and the number of, or their Cambridge multimorbidity score. We also control for the practice the patient comes from, because some practices inherently deliver more consultations per patient than others. So we need to take account of that as we look at changes in consultation rates over time. And then finally, we need to take account of this variable, which is about how many days a patient is registered at the practice. There's just a couple, so those variables here that I've highlighted there, the ones in bright orange, are our attempt to control for need. There's a couple of other factors we need to take account of. So we might expect that somebody's age and the impact that has on the number of consultations a person has is different for men and women. So the impact of age will be different for men than women on the number of consultations a person gets. So we need to allow those two variables to interact. Controlling for practices is really difficult because there are lots and lots of practices, and that would add a lot of variables into our model. So we use a technique known as random effects to try and manage that. So rather than entering practice as a fixed effect into our model, we enter it as a random effect. It's probably a little bit beyond me today to try and explain the details of that, but I'm happy to do that at a later date if that would be useful. And then because this outcome that we're interested in is a count, it can only take an integer value, and it can't be negative. So a person can't have -3 consultations or 2.7 consultations. It can only take a positive integer value. The more appropriate modelling technique, rather than simple linear regression, is negative binomial generalised linear regression. And because of that, we need to transform the exposure variable a little bit So that's what the final model looks like. And I'm just going to go back to this, what the model outputs look like. So this was the question we said we were interested in answering. How much more or less likely is it that a patient will receive a consultation in 2019 than a similar patient in 2008? So what the model gives us is a set of incident risk ratios that give us a quantification of that, how much more or less likely is it question. And this is what the results look like. So what this chart is showing us is how much more likely a patient is to receive a consultation in the years from 2009 to 2019 relative to 2008. So the model suggests that a patient would be more likely to receive a consultation in 2012 than they were in 2008, but that from that point onwards, the chance of them receiving a consultation, given their levels of need, have been reducing ever since. And to put some numbers on that, we're saying that a patient in 2019 was 3.9% less likely to receive a consultation than a patient with similar needs in 2008, and 10.4% less likely than a similar patient in 2012. So this 3.9% is this point here on the last point on the chart, this point here. And the 10.4% is comparing the chance of receiving a consultation in 2012 relative to 2019. That's the 10.4% less likely that we're reporting. So that's kind of the output of the model. But then we can ask other questions of the model. We can ask, well, how many appointments, how many additional consultations would we have needed to meet needs in 2019 in the same way we were meeting needs in 2012? So given that levels of need have changed between 2012 and 2019, how many additional consultations would it have taken to meet needs in 2019 as they were being met in 2012? And this is what the results suggest, that we'd need to deliver about an additional 11.6% additional consultations in 2019 to meet need at the service levels delivered in 2012. And we can break that down by the mode of consultation, whether that's an in-person or remote consultation, and whether that's a GP or a consultation by another healthcare professional. Now, since 2012, there's been quite a substantial change in the service model. We're delivering far more remote consultations than we would have done in the past, and we're delivering far more consultations using allied healthcare professionals. So we can change that question slightly. We can say, how many more additional consultations would it take to meet needs in 2019 as they were being met in 2012, but relative to our current or 2019 service model? And that gives us this set of results. We can also ask the question about whether there's a bigger gap between need and supply relative to 2012 in some ICBs than others. And that's what this chart is trying to illustrate. So the black dot is the actual rate of consultations delivered in each ICB in 2019. The green dot is saying how many consultations per person we would have needed to deliver to meet needs as they were being met in 2012 at the national average. So you can see that there are some ICBs, such as Hereford and Worcestershire, where there's really a minimal gap between need and supply. But there are other ICBs, such as Staffordshire and Stoke-on-Trent ICB, where there is a considerable gap between need and supply. And then in the report, we start to explore what the consequences of those gaps might be. And we have this sort of conceptual model where we're asking, what are the effects that we might expect to see if there is a gap between need and supply of GP practice consultations? And when the gap is small, we might expect the effects to be limited to things like inconvenience for patients. So a patient might not be able to get an appointment today, but they might be able to get one in a week's time, for example. Or they may not be able to see the GP they want to see, but they may be able to see somebody else in the practice. They may struggle to get through on the phone, for example. Those are the sort of the inconvenience type effects that we might expect to see if the gap between need and supply is small. As the gap opens, we might expect to see other sorts of effects. In particular, we might expect some demand to be displaced from GPs or GP practices to other locations, other healthcare services, we might expect, for example, patients to be more likely to attend emergency departments and urgent care centres with conditions that would normally be treated in primary care. And if the gap opens up further, then we might expect to see some evidence of failure demand. So this might be where, for example, a patient is admitted to hospital because a GP was unable to see them to do some chronic disease management type intervention with them that they would otherwise have received. So what we're trying to show with this conceptual model is how the effects on patients, on the health system might grow as the gap between need and supply increases. So the natural question then is, are we seeing any of these effects play out across our health systems? So this chart shows you it's a result from the GP patient survey, and it shows the proportion of patients that report difficulties getting through to their telephone, getting through to their practice by telephone, and how that's changed between 2012 and 2023. And we see that it's got steadily worse. We had a bit of a rebound in the COVID year after COVID, but since in other years, it's been a steady increase in the proportion of patients that are reporting difficulties getting through to their GP practice by telephone. So there's some limited evidence that the patients are experiencing more and more inconvenience in getting through to their practice and getting the services they need from them. What about displaced demand? So the University of Sheffield developed a metric which counts the number of patients that attend emergency departments or urgent care centres with a condition that would normally be treated in an emergency department. So they use the what used to be the HES A&E dataset and more recently the ECDS dataset, and they apply a range of filters to that to try and identify the subset of attendances at EDs that are probably dealable, manageable within primary care. And that had been going down in emergency departments, but up in urgent care centres before the pandemic. But we've seen a sharp increase in those since the pandemic, suggesting that more and more patients are going to ED for conditions that would normally be treatable in primary care. So there is some evidence here of displaced demand. And what about failure demand? Well, the measure that we use here is ambulatory care sensitive admissions. These are admissions to hospital for conditions that could be managed effectively in primary or community services if those are available in enough quantities. And before the pandemic, there had been a sharp increase in acute ACS conditions, admissions for acute ACS conditions. And although there hadn't been much of an increase for chronic ambulatory care sensitive conditions, those had started to increase as well just before the pandemic. Now, since the pandemic hit, this relates to the presentation we had last week from colleagues at the Health Foundation. So since the pandemic's hit, there's been a substantial reduction in the number of emergency admissions across the board, although the length of stay of those admissions has increased, and that's affected these admissions as well. But they are starting to creep up again, and the share of admissions which are ambulatory care sensitive are increasing over time. So generally, yes, we're seeing some evidence of inconvenience, some evidence of displaced demand, and some limited evidence before the pandemic that we were seeing some forms of failure demand. So I'm going to come back now to the sort of questions I posed at the beginning. Is there a gap between need and supply, and how big is that gap? So we conclude, yes, there is a gap, relatively speaking. So we say the supply of consultations relative to need was 10.4% lower in 2019 than it was in 2012. The gap has been growing sharply, growing since 2012 and more sharply since 2016. The gaps aren't evenly distributed. The largest gap in our patch is in Staffordshire and Stoke-on-Trent ICB, and the smallest gap in Hereford and Worcestershire ICB. And we are beginning to see some effects of the gap between need and supply in the form of inconvenience for patients, displaced demand, and failure demand. Before I finish, I just wanted to highlight a few limitations, caveats for the analysis. The data sets we're using aren't perfect. It's difficult to get a handle on both the counts of consultations and also factors that are associated with need. I sort of highlighted a few of those in the previous presentation, but they always need to be considered when assessing the results. The gap that we've reported is a relative gap, not an absolute gap. So we don't estimate need per se. We just estimate changes in need over time. So the results we're reporting primarily are the change in levels of supply relative to the position in 2012, having control for changes in need. And finally, whilst we report the implications of the gap between need and supply in terms of inconvenience and displaced and failure demand, they are observations. We're not attempting to draw causal connections between those things, or at least we're not suggesting we have drawn causal conclusions about the relationship between the gap between need and supply and those other factors that are happening in the health system. That is something we'd like to do more work on in the future. I think I'm going to stop there and hand back to Rachel and you for questions. I'd be interested to know whether the attempting to address or describe some of the methodological underpinnings for the analysis was useful or not. We could or may not include those in the future, so it'd be good to get a steer from you whether you'd like to hear more of that sort of thing in future presentations.
I kind of like it, as you know, it kind of just gives me time to get into the subject as well. It kind of just like, I recognize some of that stuff, and it allows me sort of time, a little bit of time just to tune in really to what you're trying to do, but also methodologically, people won't need this, but there's, I suppose, there's some assurance that what the data you're working with is what they know, or they don't know, or they can see the level of detail that's gone into it. They can, it's just some sort of reassurance about the robustness of the approach. I think it's also just interesting, and if people, I think sometimes it can make it a bit more accessible to other people. Like, well, actually, I can see there's some interesting results, for example, in Staffordshire and Stoke. What can we do locally? Actually, on that data set, are people able to see their own sort of portion of it, of the actual data? Is that not allowed with the conditions that you've had to access it?
Yeah, well, in the report, we try and break down the results as much as we possibly can,
Yeah,
to show people, some of those charts broken down by ICB so they can see their local results. But the underlying data is not something we own. We get access to it through a license, which actually it was just a 1-year license that we had. We don't have access to it anymore. It's very expensive to get access to CPRD. But in the future, there is an alternative data source, which is Open Safely, which will be free to access, and is funded now by NHS England. It's the Ben Goldacre research database. And in future, we'll be using that as our primary source of information on primary care activity. And I'd encourage people to look online at Open Safely and its access arrangements, and your ability to get access to it for individual bits of analysis that you might want to do. And of course, locally, people will have some areas anyway will have extracts of data from their local GP systems within environments alongside their secondary care data that they may be able to use for this sort of analysis. And we'll be putting all of the code that we used on GitHub so that people, if they wanted to, could replicate this analysis locally on their local data sets. It will take some effort to the field names, for example, will be different, and it will take some time to derive some of the variables, but ultimately it should be possible for people to replicate this analysis on our local data sets if they're interested in doing that.
Okay. I think we're due to have some more instructions and like a mini training session around GitHub and how that works and how people can access it as well. I think I'll have to line Zoe up, I think, to do another session on that. We did one about a year ago. Anyway, I've shared my screen. Stephen said there's a few observations and a couple of questions there. Would you like to pick them and respond to them? Or
happy to do that, yes.
Okay.
So that first question is about coding of comorbidities in the primary care data set. I didn't mention this when I was presenting, but the Cambridge multimorbidity score essentially assigns a value to a patient based on a whole range of comorbidities that they might be experiencing, but obviously they've got to be coded in the GP data set.
Yeah.
And looking back over time, it looks as though there were big increases in the recording rates of lots of those conditions up to about 2008, and then things have really leveled off. But there is an open question. All we get to see is the ascertainment or the recording of those conditions, and the default assumption is that increases in the numbers of people with those conditions equates to an increase in the number of people with conditions, not just increase in recording. But that is a legitimate question to ask, and that's one of the data quality issues that I think you have to take account of when interpreting the results.
And I suppose if they do increase over time, so the level of recording increases over time, does it increase consistently in different areas? Was there a big push in a particular area to improve coding for particular reasons and things like that?
I mean, a lot of these conditions are the ones covered by QOF, and you know, there's been some degree of consistency in QOF for many years. So one would expect there to be a reasonably consistent level of recording for most of the conditions covered in QOF. I suppose there's another element, which is that if GPs identify more patients with a certain condition, then they're more likely to treat them for those conditions, and that then is expressed in our outcome, the number of consultations. So I worry slightly less about it in this context than I would in a secondary care context, for example, but because I think it has a direct impact on the levels of activity that GPs carry out. But it's a legitimate question, and in the full report we'll show you some of the trends in the underlying conditions that make up the Cambridge multimorbidity score, so that people can see those and take their own view about whether they think that's increase in prevalence or increase in recording.
Or a bit of both.
Yeah, exactly.
Okay.
So shall I move down to the next one? Failure demand leads to increasing costs to the wider health system. More important is that a failure for a patient as needs aren't being met and health suffers, which is also impacts on family too. Absolutely, yes. I mean, we've talked about that as being an effect on the health system, but it's a fundamental effect for a patient. Nobody wants to be admitted to hospital in emergency. It's never a nice experience. It usually indicates some failure at some point in the health system. So yes, absolutely. There are implications for patients, not just for health systems. Were you surprised by any of these results? How important are they? I guess all of us would have had an intuition about what's happening in terms of ratio of need and supply over time. Most people, I think, would have guessed that the gap was opening up, because we all access primary care services and we know what it's like to try and get a GP appointment at the moment. The issue really we wanted to try and get to at the bottom of this report was to try and get some quantification of it. So it's one thing to know it's present, but it's another to know how big it is, because unless you know how big it is, you don't know how big your plans have got to be to try and deal with it. You don't know how many GPs, additional GPs or nurses you might have to recruit to fill the gap, how much productivity gains you need to achieve. And also understanding how it varies across areas, I think, is really important, because it does show that it's not, the analysis doesn't suggest that these gaps are evenly distributed, and the challenges seem to be much more severe in some areas than in others. So I wouldn't say I was surprised by the results per se. I was more, I suppose I was more interested in trying to get a handle on the scale of those effects and how they varied. If there was one bit of the results that I was most surprised about, it was the sharp increase in attendances at EDs that would be manageable by GPs since the pandemic. I don't think that's been reported elsewhere, and although of course emergency departments are really creaking at the moment, but I haven't seen a quantification of that GP divertible type activity elsewhere, and I was really surprised by the scale of it. So much so that I was convinced initially that it was a data quality issue, and I've gone back over that analysis many times to try and see whether there's it's just an artifact of our switch across to ECDS, for example, from the old data sets, or there's something about the way we're coding activity now relative to the way it was in the past. I can't spot anything, but I'd be happy for other people to cast their eyes over that and work out whether they think there's an issue there, which might so that it might be explainable in other forms rather than simply displaced demand from GPs.
So that's the ASC ambulatory certificate, or was it broader?
It's the one before that. It's the ones that
Right.
patients attending emergency departments for GP amenable conditions.
Ah, right. Okay. Oh, that is interesting.
Yeah.
Yeah.
Is the increase in ACSC partly due to increases in the amounts of same-day emergency care counted as an admission instead of being treated in ED and not counted as admission? Well, this is one of those ongoing questions. I think if there's a piece of analysis, one piece of analysis that we all could do with at the moment, it's a really good piece of analysis which tries to estimate some of these effects. I'd love to see if it's out there already and I've not come across it. Please let me know. But yes, there has been a lot of changes in the way we code same-day emergency care, and stripping that effect out from wider changes in demand for urgent care and changes in length of stay that we're seeing in hospitals is really tricky. But yes, that's certainly possible. That could explain what we're seeing in terms of changes in ACSC admissions. And yeah, I'd welcome any analysis on the impact of same-day emergency care counting changes on activity levels. That would be really useful for me to see. I like seeing the model explanation. Why did you use a negative binomial, not Poisson? That gets a bit technical now, but our assessment, well, a Poisson regression would make the assumption that the mean of our outcome variable was equal to the variance of it. That's a kind of assumption within the Poisson model. Negative binomial models don't make that assumption. And when we tested, it didn't look as if the mean was similar to the variance. So we went for the slightly more general negative binomial model than a simpler Poisson model. And then it was useful to see the description of the models, thanks. It'd be interesting to take some detailed case studies of patients whose demand was not being met to quantify in terms of the money, what the result of the failure was, but also a story of the patient. Yeah, absolutely. Absolutely. Qualitative research in this area, I think, would be really useful and would make it more real, I think, for decision makers as well, what the implications of some of this is. Not that the solution is simple, but nonetheless to sort of galvanise people and this comes back to the earlier comment about this being, you know, an admission to hospital is a disaster for an individual. If you can be avoided it in an emergency, it's a good thing to do. So yeah, anything to bring that alive would be really useful, I think. Is there a solution, and have the results been presented and seen by decision makers who can influence change? So in the last report in the series that I mentioned, we focus on this question of productivity changes and continuity of care. And that's where we try to sort of highlight some potential solutions to this problem. I won't attempt to cover that now because I'll do a bad job at trying to do it quickly, but that's where we go in the third report. And you're seeing these reports early. We've shared draft outputs with the chief analysts in the region, but we haven't presented it widely yet. You're seeing early versions of these outputs. But yeah, we're hoping it'll have an impact, but we'll see. The solutions aren't easy, but and obviously we've been trying to do work on improving access to primary care for as long as I can possibly remember. So it's not it's a long-standing intractable problem, but there has been some research recently which points to a potential solution to this problem, which I don't think we've been pursuing in the past, and that's what we tried to highlight in that third report. Do you think that some need in 2012-2019 might now be met by other programs we've invested in, like 111 and Pharmacy First? Yeah, it's certainly possible that's the case. I'm sure it is to some extent the case, but we're still seeing the effects in terms of inconvenience and failure demand and displaced demand. So they might be moderating the effects that we're seeing, but I don't think they're solving the problem. And again, we need more evaluation of that, don't we? We need to see exactly what the impact of 111 and pharmacy first have been. And I think it's early days on those things at the moment. A bit of evidence emerging, but I think it's still too early to say. Do you think it's fair to say that a general practitioner can deliver continuity or on-the-day urgent care access, but not support both? Does this feed into the... Can you move that cursor? I can't quite move that. Sorry. Does this feed into the disgruntlement with phone access at 8 PM rush? So again, this is kind of the territory that we get into in the third report, and that's the way it's commonly, when you read about it, people commonly talk about this tension between delivering continuity of care or access to care. That's the way it's characterised in the policy debate. You can either have one or the other, but it's difficult to have both. Again, that's where this third report comes in, kind of suggests that maybe there's another way to look at that question, which might be a fruitful line of inquiry for future policy development.
It's not quite the same thing, but I recently had a bit of a chest infection. Oh, poor me. And I went to I guess they're all over the place, but it was a winter pressures primary care thing which had been set up, which is a collection of different practices combined to treat people who are sitting there like me, making all the same horrible noises. But I suppose the amusing thing ish was the person signing me in was a GP. The person seeing me was the same GP. The person who then came to prescribe me this and the other was the same GP. He was very busy. I think that the system it kind of worked, but I was just mentioning it in terms of solutions being put in place to try and sort of respond, I guess, to and also to alleviate the problem of poorly people actually going to a GP waiting room and sort of making other people poorly as well. But yeah, there you go. Story time.
See, this is a question about GitHub. It's on a private GitHub repository at the moment. I know in the future we're intending to code all stuff in the open.
Yeah.
But the plan is to release it as a public repository as soon as we release the reports. That's the plan. So that'll be available once the reports are published. In the future, we're going to make these repositories public from the outset. That takes a bit more effort, and you have to do it tidier, which isn't my strong point.
It's a bit revealing, isn't it? You have to get things in order a little bit more, but I guess it'll be worth it. So people, Zoe responded there. She thinks that's a great idea. So there you go. Have we covered this one? Oh no, we have covered. I think we've covered all the questions which were raised on the screen there. Okay, so well, in that case, I'll just say thanks very much, Stephen, for sharing that with us. We haven't yet got you booked in for the third session, but we can definitely do that maybe in about 4 or 5 sessions time. Is it ready to go? Are you ready to share that?
Yeah, I haven't got presentations worked up yet, so that'll give me a bit of time to get them.
I like to give you that deadline. I like to think it's giving you that focus, which is a useful thing, I think, sometimes. And if anybody has any sort of reflections on one or two of the things that the points that you've raised during the presentation, for example, those GP avoidable, I've said it all wrong, but those admissions where you found that to be interesting, and like all good analysts, you just assume the data is wrong or you've done the analysis wrong, so you go back over it and make sure that it's what you do is correct, and then you with confidence you can say that's a thing. Maybe if people have come across that as well, that might be useful to share or talk about in the future. But okay, well, thank you very much for that, and I'll just go on just to share a couple of slides. Now I've unshared my screen, I'll share my screen again just to say what's coming up in the next couple of huddles. We do have lots of things coming up, so it's quite exciting. And these aren't in any order, but actually they are. So normally I'm pretty random in the order that these are put up, but the next huddle is definitely Andy and Kelly, if Andy's here now. So this is a presentation which they first did in Hacker 2023, which I'll come on to in a second, and it was very well received, and I think they've refined it since then, and they will be sharing that with us in 2 weeks today, and hopefully there'll be some sort of follow-up and sort of abstracts to build on that work in Hacker 2024. Oh, there you go, I've mentioned it already. So we've got lots coming up. There's a couple which haven't yet been booked in. So Paul Seamer's work is nearly done. So we'll be getting Paul booked in to talk to us about the impact of population and morbidity changes on healthcare utilisation, which is definitely something of interest. We'll be we've got a session on the automating the backing up of SSRS reports, and so that's using C and SSISO. If that's something that interests you, that's on the 18th of April, something like that. I'll put some dates in, and I'll share those next time. So if there's something in particular that you are really interested in, that you can make sure that you're here. Okay, so as you can see, there's a lot coming up. And in terms of the training that's coming up, we've got we're working towards the end of the financial year, so there's just 1 or 2 more training courses to be delivered in this financial year. And in fact, here we go. There's an introduction to GitHub that Zoe's going to be doing, and there are some spaces on that. So if you just head on to the website to get the links to register yourself on those, very highly rated and very useful if you want to get up to speed with Git and GitHub, and so we can sort of start to make much more use of that in the future. There's an introduction to decision quality, and that's a 1-day workshop right here at the studio, and that's on the 6th of March, and that's with Fraser Batty. We have spaces on that at the moment, so I, again, highly recommend having a trip to Birmingham and just to come for that training session. And finally, I am on the final throes of this little bit of a chest infection, so slightly losing my voice now. Timing is almost perfect. Hacker 2024. So registration is open. The call for abstracts is on. So the deadline for those abstracts is quite short. It's the 29th of February. And the very genuinely, I'm giving you preferential treatment here. The tickets are selling very fast. They sold fast last year for in-person attendees, and I so highly recommend you just make sure you get your tickets. And they only went on general sale, I think, sort of yesterday. We promoted it yesterday, so definitely get your tickets sorted for the Telford International Conference Centre on the 23rd and 24th of July 2024. So, and that, my dear friends, is it for today. So thank you again for coming. Thank you, Stephen, for sharing your work with us. It's always a pleasure. Thank you for sharing the methodology as well, which I enjoy. And I'll see you all in exactly 2 weeks' time, minus approximately an hour.
Rachel,
okay.
is it worth just saying that, I'm sure you mentioned this lots of times in the huddles, but if there's an analyst, if you're an analyst in the patch or elsewhere, and you've done a piece of work you think others might be interested in, we'd love to hear from you and book you in to present at a later huddle. So please let us know if you think there are bits of work that you've done that others might benefit from hearing about. We'd love to hear that.
Absolutely, and I think the important thing is as well, it doesn't have to be a completed piece of work. It doesn't. So the work that you present, you've spent many months on preparing, and that is very different to what the vast majority of analysts do. So it could be something just part of something that somebody's project, and it doesn't have to be a 40-minute presentation. It could be a 5-minute presentation, and we could just have a few people just coming to sort of say, this is what we're doing, and I think it makes it quite a bit more, in some senses, real to people as well out there. They know everyone's got the same challenges. Most people are using the same data, you know, and we all work, and we're all very, very busy. But if we can, if we got some hacks, if we got some insights, a different way of looking at something, or just some results, and I think we're just always people. We are always interested to know, and it doesn't need to be a finished piece of work, and it doesn't need to be posh. You know, it doesn't need to be, it doesn't have to use advanced statistical or analytical techniques. It just has to be something that I think is worth sharing. What do you think, Zoe? Am I right or am I right?
Oh, yes, very right. So on that, the NHSR community Coffee and Coding, which was set up originally by NHS England, and that runs, I think, every other Friday. I think the next one's next Friday. It's that kind of feeling. It's like, come along and share your favourite function.
Your favourite function.
Let's just get, because people feel the pressure of needing to know it all, but actually it's so nice if you just say, I'm working on this, and this is how far I've got. I've been working on things like APIs, and I had to use ChatGPT to help me, but ChatGPT was out of date. And then nice people who know more than me come along and go, I've just done a little bit of code. Does that help? And that's great. But people are all starting, and they're all starting at the same time. So just we're just like nerdy, geeky. We just want to see what you're working on. I'm always wanting to.
And so that's around code. So definitely, and there'll be analysts out there who use and are starting to use code, and we encourage that. And there are many, vast majority who aren't and don't yet.
And with your favourite Excel function. I don't know how to use XLOOKUP. I've heard it exists, and it sounds very good.
And
there'll be people keen to see that.
Absolutely. Excel will be used and is used for many years to come, as well. No, that's really that's good to know. I mean, we like to have a little chat about what people are doing, and I think some of the most popular huddles have been people just sort of sharing stuff, you know, incomplete, and maybe and asking for help, you know, who's done this, how can you help me sort of finish this, and so on. So yes, thank you, good. Thanks for that, Stephen. So sometimes at the beginning I sort of mention if people have anything they want to share, but I think it just gets lost in my sort of I forget. People, by the time we get to the end of the huddle, I forget. But it's a very, very genuine call out for if anybody wants to share their work. Okay, so if there's no more comments, we will close the show for aujourd'hui, and I'll go back up and I'll find Mohammed and and see how the analytical concepts for leaders training is going, because it was going great when I left it. Let's see where they're at now. Okay, I'll see you all in 2 weeks minus an hour. Okay, bye bye.
Thank you.